We're going to jump right into this. Chernew, you are a highly educated, highly recognized, top-of-the-line platinum card-carrying health economist.
I hate that intro.
Yes. It'll get better.
How do I get one of those cards?
So
They're not worth anything.
Mike, you just heard Scott Ramsey talk about pricing and something about value-based pricing. What do you, from an economist, strictly economist standpoint, what can you tell us about how the market might react to some of the things that you just heard, insofar as if it might push up the price, depress the price, and so on? How does this market work?
Right. The way in which this market will work is a complicated question, but let me just talk a little bit about this notion of how the prices are set and how risk gets spread. I think the key question in all of this is a combination of who's doing the shopping, what are they shopping on, and how effective is that shopping. So for example, what we found in Massachusetts when you made the providers bear risk for medical care, they shopped unbelievably well. You know, they changed a little bit of practice patterns, but boy, they sent people to the lowest cost providers, because now when they spent extra money to send a person to an expensive provider, that was coming out of their profit. And it wasn't the doctors individually, it was their organizations had groups of people that figured out how to put in place structures to get lower cost care. It turns out that that might be harder to do in oncology because the whole basically death panel notion, no one wants to, you know, the providers might have a hard time denying people access to certain types of care. I think the challenge when the risk gets spread to individuals is if an individual decides they don't want a particular product, that can be incredibly powerful, I think, for companies in keeping the prices low. If you put folks on a 4th tier formulary and no one was using their product, there would be incredible pressure, I believe, for the industry to lower the price to get off that tier. The question is, would the decisions not to use that product be correct, informed decisions, or would they not be? And so I think that the challenge for how the pressure will work on the provider is how well the people that are bearing this risk in Scott's model, how well they shop, how strongly they shop. The question about whether it's good or bad depends on whether they make good clinical decisions. If you feel good that people are not purchasing the expensive drug that gets you X weeks, you know, that might be a appropriate way of voting for what the patient's preferences are. You told me I could get 6 weeks with some side effects and it's going to cost $4,000, but I want that. There's other people that might say I don't, and you might, from a policy point of view, have to pass judgment on what you think of that outcome.
But Mike, who's doing the shopping here? You said that the shopper can exert some influence ultimately on prices, but is it the patient who's doing the shopping or the oncologist?
Again, it's going to depend on which model, exactly per what Scott said, it's how you spread the risk. In the extreme, you put the risk in a bundled payment medical home accountable care organization, patients pay nothing, providers pay everything. It's the providers that are doing the shopping. If you go to a pure patient-centered model, maybe a tiered formulary model or a high deductible health plan model, that wouldn't work because all these people would do their deductibles. But in any case, a reference pricing type model, any model like that, where the physician community or the organizations aren't at risk, the patients are paying out of pocket for the incremental things, then the patients are doing the shopping. What we're trying to do now, exactly what Scott said, is we're spreading the risk so both are doing shopping in very particular ways. And so the reason why I hemmed and hawed, despite your whole platinum card discussion in the beginning, was when there's joint shopping, some of the risk is given to the provider, some of the risk is given to the patients, not all of them have the same information. It's going to be some combination therein. And I think what you're seeing in the market now is an incredible amount of entrepreneurial energy about how to both spread that risk. The way in which that risk gets spread and the resulting behavioral responses will determine how the industry will set their pricing models. And whether that's good or bad depends on whether you think the person who's shopping, the organization, the oncologists, the patients are doing a good job. And the last point I'll make is it becomes more complicated when you add in the dynamics of innovation. When, in other words, say you had a model where everyone was shopping perfectly and they, you know, and so it was much less difficult for organizations to make profits on their products for a variety of ways, which one might do. You worry not just about the set of products we have now, you worry about the set of products we do or don't have in the future. I'm a fan of innovation, but that doesn't mean we should have unlimited innovation. So my only point is we need to think about how that all plays in,
Okay, so now you're talking about intergenerational effects.
or just across time effects.
That's
yes.
what I meant, right.
That
Next
is what I'm
genera-
talking about.
Okay, so for a guy that didn't want to be asked a question, you did pretty good, Chernew. I'll give you that.
It was the platinum thing.
Okay. So Kirby Yang, you're the Director of Oncology Medical Pharmacy Management at CVS Caremark. Can you give us a rough idea for basically the order of magnitude of oncology business that you help oversee or manage on behalf of CVS Caremark?
Sure. First of all, our client base that I refer to is going to be the payer side, which is employers as well as health plans. And so this is from a specialty pharmacy dispensing and prescription management. So we're either the largest or certainly one of the two largest dispensers for oral oncology medications. We currently cover over 60 million lives. So if we look at the prevalence of cancers in that type of population, we're probably talking over 1 million patients that have been diagnosed with cancer that we somehow are interfaced with. Now, most of that drug management is oral oncology meds.
So Kirby, relative to other spending on pharma bio, these specialty pharma products, including oncology or not, depends how you want to answer it, are growing faster, slower? What's the relative magnitude of that market versus the rest of the drug market?
Yeah, I could give you a sense that our specialty pharmacy organization manages over 20 different therapies or diseases or conditions, and oncology by far and away is the fastest growing therapy.
By far and away.
By far and away, not even close.
Okay, so given that sort of understanding about the foundation of your business, when we talk about pricing in this context, what leverage, if any, do you exert, or what influence do you have on market prices?
So you would think that as one of the largest, if not, again, the largest purchaser of specialty medications, primarily oral formulations, there would be an incredible amount of leverage. We have a little bit of leverage. We're able to extract some level of discounting. And along with our other larger competitors, Walgreens and Express Scripts, they also would usually have the same leverage. So I'd say we can move the needle a little bit because most of these medications are branded with long patent cycles, and they're long patent protection.
So that limits your leverage.
Well, today, but what we're seeing is that there are more and more entries into therapy categories, and I'll throw out chronic myeloid leukemia. You know, there are roughly 5, there used to be 6, I believe there's 5 agents now that are earmarked for treating chronic myeloid leukemia. So as we see, and same for renal cell carcinoma, there are multiple entries creating a competitive situation where you could probably negotiate better pricing.
You could, okay. So, Jeff Dunn, can you tell us, not everyone knows what the role of VRX Pharmacy is insofar as the market, and then tell us a little bit how you interact or affect or affected by pricing of these products. What's your role first?
Yes, all things clinical, I guess is the best way to summarize that. So what we are, we're a fairly new company. We call ourselves a pharmacy services management company. So we are like a traditional PBM in that we pay pharmacy claims. But where we're a little bit different is that we negotiate with TPAs and other clients to get medical and lab data. So we are placing a heavy emphasis on integrated care management and MTM. So, which I don't think is well done in situations outside of health plans.
MTM, you said?
Medication therapy management.
Okay.
So that's kind of what we do. So, you know, we're still obviously responsible for pricing, and I was just going to go back really quick if I can and comment on kind of where we are, and it's kind of my opening statement.
Go ahead.
Is that, you know, this concept, I totally agree with that statement. We need to put the health economics back into HEOR. That couldn't have been better said. This concept of value-based pricing or cost-effectiveness, whatever you call it, is not a new concept. I think part of the challenge is what the FDA requires of pharmaceutical companies is not what we as payers need, and it's not what providers need. There's a total disconnect there. So, you know, if you look at the outcomes of a lot of different studies or a lot of different drugs, they may look very similar, but when you do put that price into the equation, the delta between these things is very, very different. Again, this is not new. We've done this in all kinds of other disease states.
Delta in price or the delta in
Just the
outcomes?
delta in value, quote unquote value.
Good, thanks.
So we've done this in diabetes, we've done this in asthma, for decades, and now we're starting to do it in rheumatoid arthritis, in MS, and all these other areas. But for some reason, we're not doing it in oncology, and I think it's partly due to emotions and politics and some other things. But that's where we're going, and we have to change this. And I really think the payment reform concept is going to be crucial, and the risk concept that you brought up is going to be crucial. Because right now, it's really the payers that hold the risk, and to some extent, the patients, because they're paying copays. And providers a little bit. And so providers weren't in there, and I don't want to offend any of the providers in the office, but end of the day, we're the ones paying for the drugs. Now, pharma has no role in that. So we need to figure out how we all share in that and come to some kind of arrangement, because we're really, really behind where other countries are, and this needs to go beyond NCCN. And as a payer, though, if we say no right now, we're going to be on the front page of the newspaper, and we're going to be killed. But if we can get help doing that, then we're going to be in a much better situation.
So Jeff, but not to lose a couple of points. One is that part of your business is to try to discern relative value across these products.
Absolutely.
And you are discerning great disparities, are you not? You just said that
We
there's a
are.
big, okay.
We are seeing great disparities in all of these specialty arenas. But the challenge is now, what can we do about it?
And you can't do much about it yet.
In oncology, it's hard, again, for the reasons I've mentioned. We're doing it in other categories. So one of the things that we're doing is working on payment reform like everybody else. The other thing that we're doing, I think we're a little bit in front of the curve on, is closing formularies.
Closing.
Meaning that we're going to pick 3 or 4 drugs based on value, and we're not going to reimburse for other drugs. We've done that in RA, rheumatoid arthritis. We've done that in multiple sclerosis. Now, oncology, again, is on the table, but at some point, it's much harder. We can't say no right now, like I said. But that's where we need to help with the providers and other folks to say no. And if we can say no and only cover certain drugs, then it will give us different leverage.
So oncology drugs are really expensive, but to sort of paraphrase you and Kirby, they're kind of getting a free ride right now, right?
They have.
Interesting. Dr. Chernew.
Well, I don't think people are going to say no. They'll say yes, but. And I think the issue you'll see even in closed formularies is going to be your exception process. And although I don't know, I imagine for even the things that are off formulary, you'll have some exception process. And so the hurdles that people have to go through to get access to things will matter.
Which is not inappropriate. I mean,
No,
what we're trying to do is just at least standardize the,
Right.
the
Because
process. But there always has to be an exception.
Yeah. Can I tell a story about my wife? It's not so bad.
Depends.
This is going to be bad. We're not videoed. My wife wanted a.
Our families have met, so I'm a little concerned that this is going to come back somehow.
No, this is clean.
All right, Mike.
My wife wanted a Nissan Maxima because she was a real estate agent, and we were in the dealer, and within earshot of the dealer, she said to me, "I don't care what you do, just get the car today." My wife's a wonderful person, but the reason why that's amusing is you lose your negotiating leverage when it becomes clear you can't steer or say no. And what's going on in this discussion is, if you don't have the ability to say no, you lose your negotiating leverage.
Absolutely.
If you don't have the ability to say no, you lose your negotiating leverage. And this is a discussion about who can say no and who should say no. Patients might not be informed enough to say no in certain situations, and so putting the copays on them seems mildly odd, although when you're worried about the patient-centered things like side effects and a whole bunch of other types of things, it helps align the incentives. Physicians seem, in many people's minds, the most reasonable ones to say no because they have the most knowledge of the drugs and the profiles and a bunch of things, but most physicians didn't get into medicine to say no in particular areas. And so we are struggling, and when insurers say no of any type, they get killed. So a lot of this is sort of subtle no saying. We're going to put the providers at risk, and then the providers won't tell the patient, no, you can't have it. They'll never just mention it because no one can say Batubapap or whatever the hell these things
Thanks.
are called. No one, I mean, except for the speaker in the morning who knows the drugs. Most people, they say, well, I'm sorry, you can see this.
See, I'm so glad you brought it back to the subject at hand.
I almost didn't.
Thank you. Jeff, back on
Well,
that,
I was
though.
just going to say, I agree with that. Insurance, the role of insurance, just by definition, is not to pay for experiments. All right, and but at the same time, we don't want to just say no just for saying no. So we want to say yes to appropriate utilization. So I think our role is to kind of play the quarterback because we're in a unique position as a payer. We have the data from all of these different sources, so we can help the provider or the oncologist. We can help these types of discussions, but then in return, we need help to say no when it's not appropriate.
Okay, so Kirby, you soft pedal a little bit, but you do control a lot of this market. And what I want to understand a little bit better is, given the economic conditions that Chernew has described and what Jeff is sort of putting out there is what he'd like to be able to do, when would you expect CVS Caremark to kind of make a break or a discontinuous step to handle these costs differently than the way you have thus far, oncology in particular? Or is it going to be just sort of business as usual?
I don't think we're going to see it by the end of the year, but we are under extraordinary pressure by our clients, again, both health plans as well as employers, to start looking at ways to start bending that trend. That's across all specialty therapies. Jeff mentioned RA and multiple sclerosis, and there's others, hemophilia and IVIG. But as far as oncology, we are seeing greater receptivity for more aggressive programs. And for us, that means more formulary management, preferred drugs, step therapy, quantity edits, and other utilization management initiatives that have been pretty much standard for PBMs and specialty pharmacies like us.
So you're going to take those known or sort of existing tools or means of leverage that you just rattle off for them and sort of put the pedal to the metal on those a little stronger in oncology. Is that what you're saying?
Yes, but we can't do it just by ourselves as an organization. We need support by our clients, the payers, the employers, as well as health plans.
And you need their support because if it's just you out there, then your neck is exposed and your picture's on the New York Times the next day. Is that the point?
That is, yeah.
Okay. All right. So, Jeff, then, same breakout question. When do you see the opening where you can start exerting these things? You're speaking pretty boldly about this, and you're pretty small compared to Eng over there so far as what you do for the market.
Absolutely.
When can you take this step? When will it be accepted? Are you agreeing with Kirby that you need the players to all come along with you?
Yeah, absolutely. This cannot be done in a silo or in a vacuum. This has to be done with other people. And I agree to the point, pharma has to be involved in this. But we've had these conversations with the pharmaceutical companies. It always comes down to, well, what does that risk mean? And it usually is a small incremental rebate for us putting these programs in place, and there's no real return to that, or return on investment for that. And then plus the data issue. What do we negotiate or agree upon? What's an outcome? Versus compliance and what's appropriate. I mean, it's so subjective in oncology. That's going to be the challenge. I think it's going to be anywhere from the next 2 to 5 years, and I think again it's going to be driven a little bit by the patients themselves and then as an extension of that of the employers, because they're as it's estimated that specialty trends in general are going to double our PMPM pharmacy spend in the next 4 years. So what
Double
is that?
the PMPM?
Double the PMPM in the next 4 years. So what does that mean? It means our premiums increase. So at some point, people can't afford this. So employers are going to start asking, to Kirby's point, what are you doing to manage this? And we're going to have to do something. So I think they're going to be on board with this before the government and some of these other programs. But this is going to take years.
Okay. Kirby, to what extent do you have access to outcomes data that you might use and feedback into your leverage here?
Yeah, and that's part of the challenge here when we talk about oncology medications, because, again, as far as CVS Caremark and specialty pharmacies are concerned, our sweet spot or our interplay with patients and payers are predominantly oral oncology meds.
Okay.
And so much of the medications that were shown throughout today are intravenous or injectable meds that we don't have access to.
You don't see those.
We do not, simply because of the way benefit designs are structured.
But the reason I'm asking this is we've talked for much of the day about outcomes, the impact of outcomes. If you're a big player in the market and you have potential leverage, if you can't make these decisions without outcomes data support, what kind of validity or credibility will you have? Do you have access to any data you can use?
Well, we can certainly buy data that's out there, and there are companies and we have acquired data. I think one of the things that we do is much more research than most of other PBMs that are out there. We've done some research work on that with regards to improving adherence. I think we're going to start looking at more outcomes related. But when we get to oncology, I think we're still scratching the surface on what we can do. I think one of the benefits of a large company like ours is that we have the resources to be able to direct it towards the right people, not necessarily us. I mean, we can operationalize, we can certainly come up with designs, and we can come up with initiatives and strategies. But at the end of the day, we're going to need people like Dr. Collier, Dr. Klein, Dr. Newcomer to help guide us and direct us, because they're the experts.
Okay. I want to ask a closing question of you three experts. and it's sort of a forward-looking question. So 10 years from now, Peter Bach comes and gives his talk, and he has that now logarithmic scale, remember, about drug prices at entry. And guess what? It's flat now. It's stopped going up, and it's even starting to come down a little bit. So the market entry price of a new FDA-approved cancer drug, instead of going up logarithmically as it was, has now flattened, is now diminishing. This is 10 years from now. Jeff, what did we do right? Or maybe it's wrong. What did we do? What happened by 10 years from now where we started seeing that going down?
Yeah. Well, my fear is in 10 years we could probably give these exact same talks, and nothing will have changed. I think part of it is market dynamics. We need to figure out how we take advantage of biosimilars and generics. Right now, we are totally unprepared as payers to deal with those. We don't have the benefit design set up to incent providers.
But I'm asking you,
But
take
what
the
do-
assumption
right.
that it worked,
Yeah,
what happened?
I think it's going to be, we've gone beyond NCCN, and we've moved beyond prior authorizations, and we actually do have pathways built on cost effectiveness. And cost is going to be the driver of that, and it's going to come from the people who cannot afford insurance moving forward.
Point well made. Thank you. Kirby, briefly, what did we do?
So assuming healthcare reform actually happened and sustained itself over 10 years from now, I think what we hopefully had done right was to be able to look at patients as consumers, and with health exchanges and employers and that dynamic that's going on, to be able to be a patient and say, I've got a diagnosis, and just let me look at this site here and tell me, to the same degree, I can tell you what the best car is, value for money. I can tell you what the best LCD TV that's out there, but now apply that towards a condition or disease, and what's the best possible way I can measure it at the lowest possible cost.
Okay, well stated. Doctor, now, Black Card, which is the coolest card now, that's even better than Platinum, I'm told. What did we do right, Mike?
First, assuming it was right, the answer is we pushed risk down to providers and to patients. That's what to get the market to shop better. That's what we've done through some combination of this risk notion. We've made groups accountable. What I think is going to happen, though, is I think that Peter's graph will likely still continue. What I believe will probably happen if we do things right is through aspects of personalized medicine, some of the things we saw yesterday, we will see markets for some of these drugs shrink. That will necessitate higher price for particular drugs. But the goal in economics is not to focus on the price per dose, is to focus on the value you get in your insurance premium. So it doesn't bother me if I want an insurance policy to cover some very expensive drug. If I have a shrunken market for that, it might only add a few pennies to my broad insurance policy, and we can spread that risk around, which is what you want, as long as the drug itself in the targeted case is good. So you might have very expensive drugs used less often, and the groups that are taking risk, the providers, which I prefer because they can spread the risk more than the patients. Patient risks are useful when there's a lot of personal preferences involved and side effect things. Provider risk is better to spread across a bunch of people so you can get access to them by paying a very small premium because they're very rare.
Got it. Point well made. Thank you very much. Well, join me in thank you, Jeff Dunn, Mike Chernew, Kirby Yang. You solved it. It only took 10 years. Thanks a lot.